We are so excited to have them here to share with us, their insight and expertise. They are in the thick of this work of building their infrastructure, testing a value-based payment model, rolling out a closed loop or a case referral management system, and creating a sustainable infrastructure for their community health workers. To put all the South Carolinians in the room at ease, we are not trying to replicate South Carolina, but we are here to learn from them, to celebrate their successes, hear their ideas, and learn from their pitfalls and from their challenges. So you've seen on the agenda, we have two panels today. The first is to learn about how their pilot came to be, to learn about the value-based payment model that they are testing, and hear about the perspective of two major stakeholders. The first is a managed care organization, or a prepaid health plan, as they're known in North Carolina. And the second is to hear from the lead pilot entity that is supporting the community-based organizations in using the case referral management system and billing for that system. Our second panel, after a short break, is going to focus on the Community Health Worker Initiative in North Carolina and learn about the rollout of a single case referral management system. So one housekeeping item before we get started, you will see some index cards on your table. As questions come up, as you hear from our panelists, please write them down, and a member of the CARE team is going to come around the room and grab those questions from you. We will try to get through as many of them as possible in the Q&A session, but if we can't get to your questions, we will make sure to follow up with them in a Q&A document that will be sent out with all of the post-event materials. So before we get started, I'll let them do some brief introductions for us.
So, I am Dr. Betsy Tilson. I serve as the State Health Director for North Carolina and the Chief Medical Officer for the North Carolina Department of Health and Human Services.
Hi everyone, thanks for having us today. My name is Amanda Van Vliet. I'm the Associate Director of Innovation at North Carolina Medicaid. So lead our monthly opportunities work within Medicaid, work with Betsy on designing the pilots, and then lead the implementation and now the healthcare for these pilot program.
I echo the sentiment. Thank you for having me. My name is Ayana Simon. I work for Carolina Community Health on the MCOs or prepaid health plans in the state, and I'm the program director of the
Hello, my name is DeAndre Lee Jones. I'm the interim executive director for Impact Health, the lead organization in the western part of North Carolina, where we are in 18 counties and the far boundaries. Great to be here, and it's great to see my colleagues in person. You're correct. I'm so grateful.
And I am Amanda Bowen. I'm also with Impact Health, the interim director of programs. So I work with our HSOs, Human Service Organizations, also known as community-based organizations. So here to share from their perspective.
Okay. My first set of questions is for Dr. Betsy Tilson. The first is, could you tell us about how the state decided to make building a social determinants of health infrastructure a priority? And if you could include who the partnering organizations were that were involved, the decision-making process to make it a priority, and what was the state's approach to engaging partners, especially in the state legislature?
Yeah, I'm happy to do that. And I also want to just set the stage for all our North Carolina partners in understanding the context and the scope of all of our social justice initiatives. I know we're going to do
It's me.
We're going to do deep dives on pilot, we're going to do deep dives to NCCare 360, but I do think it's helpful to understand the context, and I promise I'll get to those questions too. So first, one of the contexts in North Carolina, one of our advantages, we are a consolidated health and human services agency, which means our Medicaid program sits within our department. Our division of public health sits within the department. Our division of social services sits within the department. Our office of rural health, our office of minority health, all sit under one Department of Health and Human Services, under one secretary. That really helps with decision-making and prioritization, especially if we want to pull resources across all of our agencies. I should know South Carolina structure, but I apologize, I don't, but that really helped. Because our former secretary, Secretary Wendy Cohen, when she became secretary in July. When she came with a healthcare financing background, she came from CMS, she came to North Carolina with a healthcare financing background and said, we really need to address what everybody knows, right? Everybody knows 80% of your health outcomes are outside of those walls. We've talked about it forever. We need to actually pragmatically make changes, and let's do it through a healthcare financing lens, because that's where the money is. If we talk about sustainability, that's where the dollars are. Let's think about how we can buy health with our healthcare dollars, not just healthcare. So she came with that very strong lens, and being the secretary over these, she had a lot of decision-making and prioritizations. Yay! So that was really helpful. We got through a lot of the bureaucracy with Family Health and Human Services, and so when I joined, she turned to me and said, you need to execute on the strategy. So I said, oh my God. It was really, really great. So that means now, because we were thinking of this through a healthcare financing lens, that meant a very important set of stakeholders are our healthcare partners. So really thinking through our health systems, thinking through our professional organizations, our plans, our payers, our FQHCs, really partnering with our healthcare partners. What was talked about, this was 5 years ago now. Everybody knew the writing was on the wall. Everybody knew they were going to have to figure out, how do I address this SDOH? And so everybody was starting to figure out their own solution, and we could see the fragmentation that was going to happen. People were going to use their different screening tools. We talked about the Craig. Love it. Oh my God, the Craig is like 50,000 pages, right? So everybody's going to start using their own screening tool. Everybody's going to start using their own referral tools. So we really wanted to get ahead of that and work with our healthcare partners and say, hey, let's align and have some shared infrastructure so we're not building siloed pieces. So that was a really, really important part of our partners. Our philanthropy is hugely important. I see Chris Combs from Duke down there. Yay! The philanthropy is incredibly helpful, especially our philanthropies that focus in on healthcare, because we were innovating, we were trying new things that didn't have sustainable funding, and our philanthropies were so incredibly helpful to support us in this innovative work and really trying to align those funding. That was incredibly important. We have a lot of data pieces of this, and so we have the Department of Information Technology and GDAP that really helping with a lot more data integration pieces and thinking through data use agreements, security, that was a really, really important piece. With MC Care 360, which LaQuana will be talking a lot more about this afternoon, or really, really important to engage the private sector for lots of different reasons, but it's hard to have sustainable solutions that are dependent upon state government and dependent upon state funding. It has to be really embraced by the private sector. So the public-private partnership, which is MC Care 360 with the Foundation for Health Leadership and Innovation, was incredibly helpful, not one, to get the flexibility of the private sector, but also the sustainability and the autonomy of it. When Dr. Cohen, who's no longer sitting in her secretary's seat, I will not be sitting in the seat forever, so really making sure that it's embraced outside of state government. So those are some of our key players. Oh, and the community health workers, which we'll talk about later, incredibly important as well, and a really key piece of the community health workers are our community colleges, because we wanted to have a consistent curriculum and training and certification for CHWs. Our community colleges is a perfect place for that. And then we also have AHAP people, our Family Health Education Center, really working closely with our providers and how do you integrate CHWs into a healthcare setting. So, a gajillion different partners, a lens of healthcare, but also that strong engagement of our CEOs and the community level as well. Now, in our legislature, I will get to that. So again, what you hear is most of our initiatives are more in the private sector, more in the healthcare sector, not dependent upon our legislature or our General Assembly or state budget. But obviously they're a key player. And where our General Assembly was most specifically really important is a lot of our elements are full population. Some are rolled into Medicaid, some are pilots, which we're talking about. The legislature was really important because they needed to appropriate the state match for the pilots. We got authorization from CMS to spend dollars in a great way, but we had to make sure that the state match was there. So that was an important piece of our legislature. And we have a good relationship with our legislature. We made sure they stayed abreast and really understood the pragmatic approach of this, that this was the pilots. We are going to be learning, we're gathering evidence, and very detailed evaluation plans that yes, this is going to improve health, our expectation is going to decrease costs, and we're going to be very structured and accountable of how we are doing that. And that's what the General Assembly needed to hear, and to know that we were going to be accountable as we go. That's what they did for create the funds, not just for the capacity building, but also the service delivery and state match. That was a long answer, but I think that context.
It's okay, because you answered part of question number 2 already. So one of the things we want to understand is how you decided what went into the infrastructure. Are there any pieces that you didn't touch on when you were talking about your partners, such as community health workers or the value-based payment model? And how did you identify which components needed to be a part of this infrastructure?
Yeah, let's be short answer because that contextual one was bigger. But just to now talk about, so it was a very pragmatic approach. And I will say, and somebody spoke, right? All of this is due to like 200 years of racial inequity and institutional racism, and that is the basis of it. We have decided to be very pragmatic and go midstream and address social needs. It's not the true underlying determinants, but it's that midstream pragmatic social need piece. So that was one decision. How far back we want to go, we decided to be pragmatic. And I'm going to talk about the different pieces, but the 4 areas that we have focused in on are core domains, similar to our food, housing, transportation, interpersonal violence, and toxic stress. We chose those 4 because, one, there is good evidence that if you don't address those needs, it increases healthcare costs. If you do address those needs, it can decrease in your healthcare costs, and they're fairly proximal to healthcare costs. And this was very pragmatic. If we want healthcare dollars to be used, we have to show how you're going to save healthcare dollars. So we were pragmatic on that, some very, very short term, like housing. So much evidence that if you can get people with high ED utilization costs, you get them stable housing, you can absolutely decrease healthcare costs very short term. Yeah, especially amongst our adults. So we have in our portfolio, we have some of those short-term investments, but not too, I'm a pediatrician, and I couldn't just do things that would only help short-term in 1 year, but we also wanted to do upstream. And so the whole pieces around toxic stress, evidence-based parenting, prevent home visiting, purpose getting that. Part of our investment is that longer-term investment, just the weight of the evidence of adverse childhood experiences, toxic stress. There's so much evidence that we address those underlying stressors that'll improve health, but it'll take a while. That'll be 10 years or so. So we have that balanced portfolio. But the premise were, where's our evidence that these social drivers affect healthcare costs, healthcare utilization outcome, and evidence that would be intervening. Those are 4 priorities. And then the elements are, we have a really cool GIS map that looks across our state. Where are those hotspots of social drivers? We have one standardized set of screening questions because we didn't want to have this kind of tower data that people are asking in different ways, because we wanted to do data integration to say, hey, if you screen positive for food insecurity, and then I'm able to connect you to food through NCCare 360, what does that do to your Medicaid utilization and cost? So having some standardization around those questions. Who's the right workforce? Doctors are not the right workforce for this. Community health workers are the right workforce. So really having to know that who is the right workforce. 4 is data integration. We're building we have a business intelligence data platform. We're pulling in data from multiple different sources, and then we are also doing what's called an ID hub, where through unique identifiers, we can link the information we get from the HIE, right? So at HIE, we have an MPI, Master Patient Index, and we have the HIE. We are linking it to data we're getting from our social service entities through an EER. It's basically, we're connecting that so that we can do this data integration. All of those activities are for all of our our population, regardless of pay, uninsured, Medicare, commercial, all of those. Then, our subset of work with Medicaid, and especially we took advantage of moving from fee-for-service into Medicaid managed care through our statewide PHPs, from the statewide PHP, we did things in those contracts. So we're requiring screening, using our standardized screening questions, you must use that. And then you must use our platform, the NC Care 360 platform, to make the referrals. Oh, and I didn't even talk about NC Care 360. So there's, and then things with the PHPs, things leveraging the MLR. What gets to qualify in the numerator of the MLR, right? Food and housing, those are medical services. Let's let you take advantage of that in your MLR, in lieu of services, value-added services. So lots of incentives for our payers to do what they want to be doing, but they haven't had the financial, it's been financially disadvantageous at times to do that. So how do we free up our PHP staff to do that? And then, that's all statewide Medicaid, and then within our pilots, which are just 3 regions in our state, that is where we use the flexibility of 1115 to actually use Medicaid dollars to pay for services. And then build upon our NC Care 360 for the functionalities that we can actually identify people, refer, trigger those invoices, and then pay for it. So that's the kind of big picture and how it all fits in. I see the 3 minutes. So the last thing I'm going to say is I know your next question, greater than what funding is lots of private dollars in the beginning, our philanthropies, lots of federal dollars, federal grants. We leveraged a lot of our COVID dollars, to fund this. And we're now using Medicaid dollars as well to fund it. So it's a whole variety of funding. No state dollars, except for the Medicaid match, no dedicated state dollars in it. It is private healthcare Medicaid dollars. Okay, that's it.
All right, and next we're gonna hear from Amanda Van Fleet. Our first question for you is, the payment model you are implementing to move from a fee-for-service model to a value-based pay model is a phased approach. Can you describe the key phases for us and how you decided on this approach?
I can, thank you. So the first thing I do want to say is that we have value-based payment strategy broadly in Medicaid as we shift from fee-for-service to managed care, to shift our payments from fee-for-service to value-based payments generally across Medicaid. That's where we're focusing a lot more on the HCP land categories and increasing the percentage of payments that our health plans spend on services, the percentage of those expenditures that have to be linked to value over time, and go into more risk-based arrangements over time. Our Healthy Opportunities pilots, it is a value-based payment model in the sense that we're paying for social services for the first time, and have a new fee schedule that we developed through about a year-long process. We went through we did numerous focus groups with community-based organizations to ask them, how are you getting funded currently? How would you prefer to be paid? Here's the difference of fee-for-service versus like a capitated payment model. Which would you prefer? And a lot of the sectors gave us different answers. The way that the food sector wanted to be paid was not necessarily the same as the way that the housing sector wanted to be paid, for example. And so we did a request for information. We got feedback from the public on how to define the standardized fee schedule and how to price it. We had a national and local advisory council with national and local experts in the food and healthcare space that also advised us on how to set standardized service definitions for our 29 services that we're testing through the pilot, the Healthy Opportunities pilots. And then we took all of our input and assumptions and had our actuaries actually price the services. And so that's how we ended with our fee schedule that has 29 services that address food, housing, transportation, and interpersonal violence and toxic stress. And then a set of cross-domain services like linkages to legal supports and holistic high-intensity case management is in there also. And so that's how we developed our fee schedule that we are using to start the pilot program. We did negotiate our waiver when we had we still have a Democratic governor, but we were working with the Trump administration at CMS at the time, and it was very important to them. My understanding is that it was very important to them that we move this fee schedule towards value-based payments over the course of the pilot. And so our waiver currently specifies that we move along the HCP land trajectory to use shared savings models in our Healthy Opportunities pilots. Our thought as of now is that it's been really hard to get our HSOs to even, they're functioning as Medicaid providers for the first time. They're having to abide by, Medicaid program integrity standards. They're shifting the way that they're paid to get paid retrospectively based on a fee schedule, which they've never done before. It seems really challenging to us to ask our human services providers to basically function as ACOs, which some of our largest health systems in North Carolina, it's even hard for them to be successful in those models. So we are actually currently requesting some modifications to our waiver that kind of loosen the requirements around moving specifically to shared savings models through this pilot program. We do still want to move to value by seeing, for example, infrastructure improvements, and then seeing that they're actually delivering services, and then seeing that they're actually delivering high quality services, and moving more towards value, but potentially through more of incentive payments rather than shared savings or potentially risk-based arrangements, because we're worried that it's already hard for them to participate. We don't want to make it so hard for them to participate that they don't. So.
Well, my next question is, what are the outcomes you're hoping to achieve or see out of this work?
Yeah, great question. So we, Dr. Tilson spoke to this a little bit, but we have a very robust evaluation design. We are working with University of North Carolina Shep Center for Health Policy as our external independent evaluators, and they have developed a pretty robust evaluation design. The outcomes for that evaluation are hypotheses that we are proposing to see. One is looking at the role of our network leads, and we expect them to be really vital in being able to form these networks of human service organizations and allowing them to participate in the Medicaid program, provide technical assistance, allowing them to provide high quality social services through Medicaid. Our second is that the pilots will increase the rates of social needs screenings and referrals to community-based organizations to meet those needs. The third is that the pilots will improve the actual social needs of members that are receiving pilot services. And then we get more into the healthcare outcomes where we expect that members receiving pilot services, that it will improve their health outcomes, decrease total healthcare expenditures for those members, and utilization, thank you, and improve healthcare utilization. And with that, we're looking both at increased primary care and preventive services and decreased hospitalizations and ED use.
So as you were approaching this work, my next question is, what was the impetus for deciding to pay human services organizations for their services?
Yeah, great question. So I think Dr. Tilson spoke a lot to this about our secretary coming from a healthcare financing background, and about the fact that we all know that up to 80% of a person's health is determined not by medical care, and yet we spend 90%, I think, of health-related spending. It goes towards medical care. And so I think a vision from the very beginning was to really pay for social services in the healthcare context. And so we were developing all of these infrastructure systems like the screening and referral, our NC Care 360 platform, screening questions. And so we really wanted to add in the payment piece through Medicaid and show that meeting these social needs in Medicaid did actually improve health outcomes and healthcare costs. And so to do that, we're treating these services as Medicaid services and our HSOs really as somewhat as Medicaid providers. We're trying to be lenient on them so that they are able to participate. And so along with that came our fee schedule and reimbursement for the services. And I also think that a big part of the concept originally of the pilots was really to invest in local communities and local community-based organizations. And to really, we recognize that there are lots of community-based organizations throughout North Carolina that are doing amazing work, and so we wanted to offer them an additional and predictable source of funding in addition to, on top of the funding that they're already receiving, so that they could build their capacity, they could hire more staff, they could serve more people, and we're hoping to address health equity and specifically looking at minority-led, community-based organizations that are in the pilot programs, and so trying to really focus on health equity and build local community capacity.
And my last question for you is there any particular success that you want to highlight that's come out of this work?
Yes. I mean, to be very honest, I'm frankly just so proud of all of the department and all of our partners that we have taken what I feel like is an incredibly bold vision and actually made it a reality. I mean, I think there are many alternate universes where this could have never gotten off the ground. You know, and we made some really conscious decisions in doing that where we, you know, I mean, it was really hard. And we kept running into issues where we could do it unperfectly and get it off the ground, or we could try to perfect it. But if we went for perfect, we were really nervous we would never get it going. And so we really aimed for kind of what's our minimum viable product that we can launch and get off the ground and get going and start learning. And then iteratively really try to improve it over time. And so that's what we went with. And so it really is an ecosystem model. We have 5 health plans. We have 5 clinically integrated networks. We have 3 network leads. And we have around 100 community-based organizations that are all participating, and they all know their roles and responsibilities, and they're executing on them. We built this new technology platform and built on top of a technology platform, and that technology is working. HSOs are invoicing based off of a fee schedule for the first time, which is really a really big deal. We're also, our health plans are turning those invoices into encounters, and we're receiving non-medical encounters into our Medicaid analytics system so that we can look at members' medical and non-medical encounters at the same time to look at their health holistically. So I think we've just done a lot of really nitty-gritty on-the-ground things to get this up and running that I'm really proud of.
Wonderful. So next we have Ayana Simmons. My first question for you is, what phase is your organization in with the payment model?
So, this is on? Yes, okay. So as Amanda indicated, at this point, we're paying invoices. We're in phase 1, whatever that is. Our purpose right now is really to make sure that our members are receiving services, our HSOs are being paid timely. I know one of the questions you're probably gonna ask me is what are some of our challenges? I'll get there. But we are in phase 1. We are doing our best to make sure that we can pay for our services in a timely manner. Our invoices are correct, they're accurate, we're not getting a bunch of disputes back. So we're in phase 1, pay the invoices.
So my next question for you is, what changes did your organization have to make to align its core business functions or activities with the payment model?
There has been a lot of work done. As you all can imagine, and as Amanda indicated, this work is not traditional Medicaid payments. Carolina Complete Health is a prepaid health plan in North Carolina. Our parent company is Centene. So we are working between our plan, finance, and accounting team and then corporate resources who have their plates full and don't care what's happening in North Carolina.
And how do we've had to create a lot of workarounds to make it happen, if I'm gonna be honest with you. We are in an invoice system right now. We're used to getting claims to pay, so we've had to create an additional system to pay those invoices. We're working on our claim-based system. Workarounds needed for that. How do we even add these human service organizations into our financial system because they're atypical providers? We are not contracted with them. There's just a lot that we have had to do to make this work, but because we stand behind what it stands for, we're doing it. Not perfectly, right? But enough to get it up and going. On the finance side, like I said, there's been a lot of what can we do to make this work? Our IT side is a whole different system. So we've had to build a bridge between Insecure 360. What does that look like? The invoices that are coming in. We have had to create different systems, even for our grievance and appeals for this program, because these are atypical providers. They're just handled very differently. So there's been a lot of trying to fit this into what we're used to as traditional business. A lot of teams, I feel like I interface with everybody at this point. Like I feel like I know everybody now, and I've been here for 2 years. Because it's needed. I mean, it really is. It's not just care management. It's not just our finance team. It's not just our IT team. We have meetings every week with like 50 people on trying to figure out, okay, who needs to do what. And so it's been challenging work, but it's been great. It's been great.
Well, you've shared with us all the positive things thus
All
far.
right.
So, have there been any barriers to this work? But on the flip
No.
side, how have you addressed them?
Okay, Amanda, close your ears, okay? Okay. We have definitely had some challenges. I would not be honest if I said we didn't. Buy-in has been one. We launched in July of last year, and this launched not even a year later. So I feel like we are trying to get our feet underneath us as a health plan, and trying to figure out how do we just pay claims. And then here I come saying, yeah, great. So what I also need you to do is, that's been a bit of a challenge. The way that the state of North Carolina is set up as far as our care management entities, has been a bit of a challenge for the program, because our care managers are integral in this process, right? They're doing the assessments, they're making the referrals to the human service organizations, but they don't all fall under Carolina Complete Health, right? So we have clinically integrated networks, we have oversight but are not responsible for them, and they have a large majority of our members. For our plan, about 80% of our members are care managed outside of our organization. So that has caused some fragmentation as far as the referral process. We are telling members, call into member services if you want to be assessed, but then there's this extra step that people may not be aware of is we have to figure out, are you a Tier 3 clinically integrated network? Are you contracted? Who's your care manager? Is it internal? Is it external? And then get them over, right? So that has been one of the things that we've struggled with. Capacity in some of the human service organizations. Our plan is 41 of the 100 counties, and so we actually only have membership in one of the pilot regions, but it is the eastern part of North Carolina, which has a lot of rural counties. And so a lot of the services that we're seeing that members need may not be as robust in some of those counties. Transportation, for one, right? A lot of these counties don't have robust public transportation systems. We have the funds, but they don't have the capacity to meet those needs. So we're seeing that. I will say one other thing. We have a lot of people who would benefit from being linked to these SDOH services who may not qualify based on the physical or behavioral health condition, right? So we have like healthy members who have housing needs or healthy members who have food insecurity, but we're held to a standard of making sure that we're looking at some of those more chronically ill individuals. And so there is a subset of our membership who would benefit from this program, but are not actually eligible.
Okay, and because I want to end on a positive note, what are you most proud of?
that we did it. I remember like starting and it was like, when launch date got moved, right? Launch date got moved and then it was like, all right, February 1st, but then it's gonna be phased. And I was just thinking to myself, the social worker in me kept thinking to myself, please don't move this back again. Because what the program really, like I said, stands for is helping people, whether it's clunky, whether, we have a subset of our membership who's not eligible. What we're really doing really helps. The food, when we talked about food and housing, those were our top two before Healthy Opportunities launched. So be able to make sure that these families and particularly children are able to, get these meal boxes. They have the delivery option for those who have multiple needs. Transportation is an issue. You can't get to the food pantry. So we did it. We're doing it, I should say.
And I'll just say, we did it in the middle of a global pandemic.
Correct.
So,
Yes.
like,
Yes. Absolutely.
Thank you so much, and we're gonna hear from Dion Greenlee-Jones next. And my first question for you, this is a long one, so bear with me. Your organization, Impact Health, serves as one of 3 pilot entities that supports a network of nonprofit and community partners who are delivering services to high-risk Medicaid beneficiaries. These organizations, in which you refer to as human service organizations or HSOs, receive Medicaid reimbursement for private health plans for services related to housing, transportation, food, or interpersonal safety. Can you describe the types of support you provide these HSOs?
Before you begin, we are visual folks, so we have a few slides to accompany what Dion is about to say. If you want to go to the next one.
And we're also going to go back and forth a little bit. So this is really a team effort. Yes. One of the things I wanted to say, just to also level set a little bit, is we believe that Impact Health is literally successful because we're a new nonprofit. We are just beyond a year old. So imagine being new to this. We were created by Dogwood Health Trust specifically for this pilot. So when you talk about another layer of success, which is amazing, that again, we are a pilot within a pilot, but we're also just a year old. So we're doing it. And it's an amazing feat to have us come from the place where our other fellow network leads, direct service providers that have been in existence for a lot longer period of time than Impact Health. So we're excited that one of the primary goals is for us to support our HSOs on the ground, just amazing community-based organizations, HSOs, and we'll talk about in a minute about doing this all through what we call a movement of health equity, because we do look at it, an equity lens in everything that we do. So how do we support our HSOs? Because again, they're critical to this work. We are having all types of technical assistance opportunities for our HSOs. We are having site visits. Every time an organization applies, we do a readiness assessment with them and sit down and really talk with them about their challenges, what they envision, how they wish to be a partner, sitting down with them and talking about their capacity building budgets and what does that look like. Because again, when we have organizations apply, because we are so rooted in how do we get organizations what they need to succeed in this pilot, what we are doing then is saying not no, but how can we help you get ready? If you're not ready at that particular time, then how can we discuss capacity building money? How can we discuss infrastructure? How can we help you with your staffing needs? That's critical because HSOs, community-based organizations, and then other organizations that we don't always see at the table, faith-based community organizations, whether or not people think about it, original social determinative health organizations that have not always been invited to those major stakeholder tables to discuss this. But then we also have weekly HSO office hours, 38 to date, where we're asking you, are there conditions, are there questions, are there issues you're experiencing? How do we provide technical assistance and training? What does that look like? Where there being over 100 of those interactions at this point about just anything that you might need assistance with. And then also doing more strategic, domain-specific engagement. So how do we talk with you if you're in the food domain? What are there particular issues that are affecting all of our food domain organizations? How can we help you address those issues? So we're really interested in supporting our HSOs because without them, we don't have this work. We need to, and I need to make a point that when we talk about supporting our HSOs, we're also talking about honoring the communal knowledge of our community organizations that are already on the ground. And I'll talk more again about how critical community health workers are in this work. We work in partnership with local organizations and those that are already on the ground that know the communities perhaps better than we are. We know them as subject matter experts, and we give honor and credit to them for making all of this work possible.
Thank you. So you shared about this robust technical assistance and training infrastructure that you provide. Could one of the two of you share what are the most common challenges that you're seeing in this context that the human service organizations are facing?
Yeah, fantastic. Can you go to the next slide, I think it is? Nope, keep on going. There we go. Okay, so during our capacity building round one, we were able to fund 132 jobs within Western North Carolina. That is 132 adult learning styles that are completely different. They are housed at about 42 different agencies. So folks are gonna hear things incorrectly. They're going to be doing other programs as well. And they needed one place that they could go and find everything they needed. So we designed an HSO portal, and you'll see that it's divided by the different domains. So that walks them through everything they need to know to ensure that they are providing a high quality service. In addition, it gives them everything they need to know about invoicing. This was a game changer for us because prior to having an HSO portal, everything was stuck in email. And I don't know about you, get a bunch of emails every day. I'm gonna lose documents if they're only emailed to me. In addition, everyone has a unique login, so they're able to reach out to Impact Health for assistance as well. So they don't even have to remember my email address. They literally just have to get into this HSO portal, and we tell them they then have access to everything they need to know about HOP. And I'm not kidding. They have the communications plan, they have an eligibility flyer, you name it, it is in there. And that has been an amazing change for us that now they can go to one site. If you'll go to the next slide, another thing that you have heard already, this is a completely different way of doing business for our HSOs. For them to be providing service and then doing a reimbursement. Our PHPs have done an absolutely fantastic job in terms of reimbursing folks, but that's 60 business days that they have to reimburse folks. They're not used to waiting for funds. Our capacity building funds have been crucial as our HSOs are learning this different service delivery method. Due to our training in our HSO portal, 90% of our invoices have been approved on the first time. You'll see up there how much has already gone to our HSOs from PHPs. I just want to pause there. PHPs are paying our HSOs for social determinants of health. And look at that number. I don't remember it. I think it's 200. It is a big amount, I know that. And that is what we are most proud of.
Okay, my next question is a really important one. So in 2020, South Carolina formed a design committee to begin building a roadmap to social determinants of health. One of the key takeaways of this work is that you cannot achieve health equity if we don't address barriers like structural racism and social isolation. How have you kept health equity and race equity at the front of your work in North Carolina?
And I'm thinking it might be the next slide that talks about health equity. Is that one? Okay, I'm sorry, I can't see. We specifically look at also targeting BIPOC-led organizations that we know are, again, critical and are doing a lot of the work, particularly with individuals that look and are represented in those organizations. That's something that we're very proud of. The fact that a major success story has been able to recruit smaller organizations that are BIPOC-led, and then give them the capacity building funding and support to become active on the platform. And that when they've been provided that support, they're doing the work that much larger organizations are doing. That's something we're very proud of. The other pieces about this also is that we're researching what I like to call pilot within a pilot. Again, how can we continue to utilize community health workers? How can we look at those that are in the community that represent demographics that you don't, again, always see represented at the stakeholder table? We're doing community engagement opportunities. We'd like to talk about a county by county, I like to call them days of engagement, where we go into counties and say, let's sit down and have a conversation about all of what we're wanting to do and what can you help us with. Again, from the standpoint, from an equity lens, you're gonna know the communities you're serving much better than we are. We want to be in partnership with you to do this work and to make sure that organizations come to the table and have what they need to be inclusive, because that's not always the case. We know that, it's not always well spoken about, but how can we also make sure that we're looking at this? And when we do the readiness assessment with our organizations, we ask them specifically about their DEI work. How are they doing this internally? How can we support that? Do you have bilingual information, materials? If someone would hold up one of the cards, I've got an example of what we're doing PR and marketing, and I've got some for everyone, where this is bilingual. Yes, and I think there is another slide that has an illustration of that. But again, having it bilingual, but we also work with the Kuala Boundaries, with the Cherokee Eastern Band. And so can we also, and are in conversations with them about having these also translated into Cherokee, the native languages in different counties. That's critically important to us because again, we're all in this together. And so for us, equity is at the top of this. And then looking at the kind of technical assistance and training that we're providing around all of this in partnership with what the state is already offering along the lines of diversity, equity, inclusion training, making sure our HSOs have access to that and know about all of its offerings. So we're really trying to do a lot of different things to bring everybody at the table, acknowledging that that has not always been the case.
And Amanda, if you have anything to add, feel free.
We also feel that with this RAC card that's gone out, it is also reaching populations that might not be going to the doctors, might not be calling their PHPs, might not be thinking that there is help out there through their actual Medicaid plan in order to address the social determinants of health. So we think that this is a fairly easy way to get the word out.
So I have a similar question for you about the barriers that you've experienced and how have you addressed those in this work?
Yeah, certainly. So we have very much learned that with our invoicing, we needed a billing specialist within Impact Health. And so our billing specialist is the one that communicates with our HSOs and helps with all of the bumps that may come with the process of billing. Thankfully, there have not been that many bumps, but he is there to help with the reconciliation. He is able to help with figuring out where payment statuses are, things along those lines. Another thing that was not necessarily on our radar was how much of a partnership we needed with care managers. And so we have since developed that somebody within Impact Health is a direct contact for any care managers to provide any kind of assistance in terms of knowing the HSOs within our network and knowing exactly who would be the best HSO to refer to.
Okay. And then closing with successes, what are you most excited about? What are you most proud of?
Perfect. If you go to the next slide, we want to introduce you to two folks. On the left side, you'll see Sarah. Sarah works for a local food pantry. They were initially, before COVID, doing that it was a market style. So folks were able to go and pick out what exactly they wanted. But hey, COVID happened and that changed so much service delivery. So instead, they were doing drive-through boxes. And so when they applied for HOP, they said, we really want to get back to doing client choice. We really want to make sure that the client is getting what they want. And we said, perfect. It is part of our definition that it has to be a client choice box and that you are also working with the client to ensure that they are provided with foods that are meeting their medical needs. So Sarah said, could I meet them at the grocery store? And that could be the food pickup location? And we said, yes, yes it can. So Sarah's model right now is that she is, if the client wants, they are going to the grocery store together and they're picking out the food that they want together. And then in addition, they're also researching the healthy recipes together. And so it's just a huge game changer in service delivery. I said, hey, Sarah, I'm gonna put your picture up to a bunch of folks in South Carolina. Is there a client story you want me to highlight? And she said, yes, let me tell you about Jean. Jean was discharged from the hospital and she was so weak that she could not even have a first conversation in terms of what food she wanted within her food box. So Sarah just went ahead and packed a food box with her, for her that contained a lot of familiar items. Because this was through HOP, she also knew that Jean was on a very strict diet that she could not have a lot of salt. So she was sure to include things like unsalted sunflower seeds. She also introduced her to quinoa. And so through this partnership, Jean has found amazing healthy snacks that have kept her out of the hospital. In addition, she now knows what quinoa is. And also all of the different recipes in order to go ahead and make them. Then next to Sarah, we have Trey. Trey works for an agency that also, due to COVID, completely changed their service delivery model. They used to do solely, a car was donated, and then they would fix it, and they would give it to somebody. However, there was a chip crisis, I think, with new cars because of COVID. And so all of a sudden they were finding that they were not getting a lot of donated cars. So they started doing car repair instead. And they said, hey, we've only done this so far in Buncombe County, but we think it's needed in all the rural counties of Western North Carolina. Could we try this out through HOP? And we said, yes, yes, you can. So they have since expanded into 6 counties. And so they are able to provide a service delivery method that's changed because of COVID and is so vital. Western North Carolina, we have Asheville. Asheville has a reliable public transit system, but hey, we cover 18 counties. If you're outside of Asheville, you do not have reliable public transportation. There's options, but it's not reliable. So having this car repair within our network has been amazing. So similar, I said, Trey, you're gonna be in front of a bunch of folks in South Carolina. Is there a story you want me to highlight? So he told me about Robert. Robert was going to visit the doctor just for a regular wellness appointment, identified that yes, he did have several social determinants of health needs. And so as a result, he was referred to a few different places. One of them was to get his car repaired. This is the first time that Robert has had reliable transportation in 5 years. 5 years of not having reliable transportation completely changes someone. Robert is now able to go out and see his friends. He's able to go to appointments and he has steady work. All of that because of reliable transportation. In addition, he identified that he had a housing need. So currently, his wood stove is also being repaired so that he'll have heat come the winter months. This is all because of HOP. When we talked to Robert, we said, hey, could you give us, how exactly has HOP impacted you? And he said, I am not lying. HOP has changed my life. And I don't know if there's a better line that we can close on.
Speed round, final question for everyone on the panel. If you could leave us with 2 pieces of advice as we approach this work in South Carolina, what are they?
Don't strive for perfection, right? This is a huge elephant to try to get a handle on. So, and Amanda articulated that really well. Don't strive for perfection. Just try, and with your partners, refine as you move forward, because if you wait for perfection, you will never get there. Second is try for alignment. As much as we can align partners and systems together, again, we showed examples of the same screening tool, the same referral platform, align as much as possible. That those are the two, I think, key pieces. And then I will also just say, I almost would say two, but those stories, like, I don't know, you saw that I kind of teared up a little bit, because that is why we're really doing it, and that's just amazing. So remember why you're doing what you're doing is you are changing people's lives in a very pragmatic way, which is just the most rewarding thing ever.
I would say proactive and early communication with all of your partners. I think that we have tried to really engage all of our stakeholders that are involved with the project from the beginning, and trying to see run our ideas by them, get their input, incorporate their input as much as possible, and they're the ones actually doing the work. And so I think buy-in of partners is extremely important. I would also say, kind of similarly, but start somewhere, even if it's not with a holistic program that does everything. You know, I mean, if you can start screening, or start looking at race and ethnicity data, and looking at your data and seeing equity disparities, and then from there you can do something about it. So I would say start somewhere, and also keep equity, just being really proactive about equity and having very targeted ways that you are trying to address equity at the forefront.
I would say that whatever program you all decide to implement, allow for freedom within a framework. Of course, criteria is important. You know, making sure that you're hitting your targeted population is important, but allow for some freedom and flexibility within that framework. I will also say that remaining flexible, right? I feel like every week there's something different. But being flexible, and then also making sure you're innovative in how to implement whatever that new thing is for the week or the month, I would say would be the two things. So allow for freedom within the framework, and then flexibility and innovation.
I think I want to echo a couple of things here. Again, I can't stress enough about honoring community-based organizations. The communal knowledge and elevating them to be successful, and not asking how we can help them, but how honestly they can partner and help us with this initiative. They're just critical, and whatever that looks like, being able to listen to that. The other thing I think is important to understand is we talk a lot about data, but I also want to defer also to the on-the-ground entities that are doing this work on a daily basis. And for those who are data crunchers, again, it's so invaluable. But I'd recommend also that people don't get stuck behind data. If we know that there are certain conditions that have been obvious in certain counties over the last 2 decades, we're pretty certain that the needle hasn't been moved a lot, because people say, well, let's do another study. Let's understand, I'm sorry, the elephant in the room. Let's understand that the data is critical to reinforce the case that you're making, but know that the community organizations already know what the needs are, and we need to defer to them to move forward on that and not get caught up in another study, because sometimes they're also tired of being surveyed. So how do we honor what they bring to the table so that they can be partners with us to help address the needs that they determine are priority, not us, but that they help determine a priority. I guess that's it.
Okay, well, our next session is the Q&A with your great audience questions, and my first is actually for Dion and Amanda. So how have health service organizations been left behind because they didn't have the capacity to be a quote-unquote provider? And kind of related to this, how do you address organizational equity with capacity and participation?
I'll take the first part of that, and the first part of that is we have an HSO that has 2 employees. 2 employees. That is all that they have, and they're able to hop in because it's working with their already set service delivery model. It's just enhancing it. So it is something that how HOP was designed, it wasn't, hey, if you're going to doing this, you need to do everything you've been doing completely different. What we always say is that HOP was designed to fit into how you're already doing. It's just this extra step of doing an invoice, which is just pressing a few buttons within NC Care 360. So I would say that we have worked with our HSOs to build up their capacity if they need it in terms of staff members, but more than likely, it's something that they're able to just add in to how they're already doing their current service.
And again, when we're talking about equity, particularly in supporting our community-based organizations, training and development, what haven't you had an opportunity to do for your staff because maybe you didn't have the funds? How can we help with capacity building funds to help you with your equity journey? How do we provide training and resources? How do we provide memberships? We're developing also an HSO toolkit that could be what we also understand when it comes to equity, what that means, access to information. We know in rural Western North Carolina, sometimes internet connectivity, and I'm sure it's the same in other places, is not what it should be. We also acknowledge that when we talk about health equity, are we talking about also infrastructure? What do you need as far as capital expenditures that might need to get additional approval, but that would make your organization more effective and you'd be able to be as successful as you can be? Equity looks very different, and we look at it from many different ways as to how do we help you become successful and you be able to have language classes for your staff, be able to make sure you're doing outreach in the way that you want to that maybe you weren't able to afford to before. How can our capacity building funding support help you become a more equitable organization and how you work to support the clients that you're working with?
Wonderful, thank you. So my next question is for Dr. Tilson or Ayanna Simon. How and what are you using to receive the non-medical supplemental services on encounters? i.e., did you create a mock CPT HCPCS code to receive?
I should be able to answer that question, but that's my encounters team. I can tell you what I give them. And so, okay, great. So we take the invoice information and response files, what we send back with all of our member information. It has coding for short IDs. We created like codes for all the different services, and they use that information to get the encounters back. That's the extent of my technical knowledge.
Yeah, and our encounters team at the state is working with NC Care 360 and the health plans as well. We did develop kind of a standardized encounters, like a way to fill out the encounter from the invoice to give that as a model to all of the health plans. And now Unitas as well, so that they'll be able to take the information from the invoice. We give them some dummy codes to enter where they need to be in the encounter, so that they have kind of a model to go on.
And the second part is, are invoices created by the CBOs or the referral platform itself?
I'll speak a little bit and then I'll let Amanda talk about it. Right, so again, part of it is by building the statewide infrastructure and then enhancing on top of that baseline structure to serve the needs of the pilot. So this is part of what we call the advanced pilot functionalities, where we've built this extra enhancement. One, we wanted to be sure on the CBO level, it was as easy as possible for them to create an invoice. We didn't want them to have to go to another system and make it really difficult. So within NC Care 360, as part of this advanced pilot functionality, the CBOs, as they're already documenting their service delivery through a couple of buttons, can generate, turn that into an invoice. That invoice then goes to the HSO, makes sure that that looks good, and then up to the PHP, and then the PHP does their conversion into an encounter, and then triggers the claim from the PHP back to the HSO.
Not complicated.
Well, actually, no. No, not really, actually. We tried to make it as simple as possible, but it was the advantage of having this baseline of a platform, and then the beauty of that is we can innovate on top of that.
Perfect. So this is a long one. Is the cost for addressing food insecurity and housing needs part of the cost of care for MCOs over the whole state or just in the pilots? And is the cost of reimbursement tied to only the referral to services or actually achieving the goal, i.e. getting someone into housing?
I'll speak a little bit first from the state, and then I can pass it to Ayana. So all of our managed care plans are responsible for addressing social needs of Medicaid beneficiaries, regardless of whether they're in the Healthy Opportunities pilot or not. Only members that are in the pilot are eligible to have our 29 services covered by Medicaid, reimbursed by the health plans. But we are looking at social needs and improvements in social needs across all of our Medicaid members, those in the pilots and not in the pilots. And so we've asked our health plans, and they've really come through in offering value-added services, for example, that address social needs. So they're putting in their own money to do that. Like I said, we will have value-based payments where the health plan risk and provider risk increases over time. And so with that, I think there's inherently incentive for the health plans to invest upstream and address social needs, and they have some incentives like investing in community social needs that they're able to count that in the numerator of the MLR. So there's certain financial incentives for all of our Medicaid beneficiaries, but only those in our pilots get these specific 29 services reimbursed by Medicaid.
Yeah, the only thing I would say, so our plans are capitated at risk for the general, right? So the pieces that the plans are doing on their own outside the pilots, they're held at risk for that total cost of care. Then the part of our 1115, we got the authorization to use dollars in this novel way. So that's kind of an extra bucket of dollars that the PHPs can tap into specifically within the pilots. And then our evaluation, as Amanda was saying, we're certainly looking at evaluation of the folks within the pilots, but we also can compare to outside the pilots. And then to triggering the payment, again, we have 29 service definitions. And so once you deliver a service that is defined by that service definition, that triggers payment. So sometimes it's case management to help with housing navigation. And so as long as you meet that service definition, you get payment. You don't have to wait until somebody's health outcome is better, as long as you are delivering those services on those 29 service definitions. Anything you wanted to add?
I don't.
No.
I feel like the question's been answered.
Okay. So could you talk more about the program integrity process for HSOs?
Do you want me to start?
Yeah, you can start.
Okay, I'll start. So this has been a challenging nut to crack because we recognize that most, if not all, of our HSOs have not participated in the healthcare system, let alone Medicaid, and so are not used to Medicaid and program integrity standards. So we've done a couple of things. We're trying to reach a happy medium as much as possible, where our state program integrity team is comfortable, and they think CMS would be comfortable, while at the same time recognizing that this is a pilot. They're not technically Medicaid services, and so we have a little bit more flexibility with them than we do with traditional Medicaid services. And we try to use that as much as possible to really make the program as manageable for the HSOs as possible. So an example, we went back and forth for a long time on whether to enroll the HSOs as Medicaid providers or not. And I actually was a pretty big proponent of not enrolling them as Medicaid providers based on some of my other experience at CMS, where we tried to do the same thing and it did not work very well. So what we did was we created a new provider type specifically for pilot HSOs, and we could configure that as we wanted. And so we kind of kept the minimal program integrity standards that were required and absolutely necessary, while removing certain program integrity aspects that may either not be required or maybe like very large barriers to participating, like fingerprints of board members, for example. And so because we were able to create that unique provider type, I think that made it easier for HSOs to enroll since they didn't have to meet every standard of being a Medicaid provider. But it was still hard for them to enroll. It's been a big challenge. And so there was, once we got a dedicated person from the state to really work with the HSOs and kind of really like handhold them and along the way and kind of go through the application with them, I think it really helped, but it was still hard. So that's an example of kind of how we're trying to balance that.
Just wanted to also say that, again, we just walk hand in hand with the HSOs. We knew that this was going to be challenging in many respects because they had not acted as billing entities previously, making sure they have any kind of technical assistance support. They had to undergo OIG checks where those working with clients in the pilot had to make sure they had to go through background checks. We supported all of that. It's just some of the integrity requirements of the contracts and with CMS. With that being the case, we're walking hand in hand with the HSOs. Every time there's something, we have, again, weekly office hours, and I'll have Amanda, she could speak more to some of this, but we really wanted to make the burden, the administrative burden, less than it could have been. And some of this also is making sure we have partnership buy-in with the HSOs. They're excited to do what they need to do, what's required, if they feel supported. And we really worked to make sure that was the case.
I would say also in terms of program integrity, how I mentioned that we have about 40 HSOs. We work with them to say, this is a high quality service delivery method. Yes, we want this to fit in the best way that you're already doing it, but here are some things that you have to do. And those things are also part of the invoicing structure. So for example, if somebody's doing housing navigation support and sustaining services, they have to include a housing stability plan. And so we worked within our network to say, okay, what do we all agree should be on a housing stability plan? So it was our HSOs coming together to say, here's what I ask, here's what I ask. Okay, let's put this all back together. And then also by creating a template, it is easy for the PHPs, it is easy for the care managers to see the similar kind of documents. So it's not like, okay, HSO A is submitting something that is completely different than HSO B. So that's another way that we are working on program integrity in terms of the service delivery. That it is, yes, you are free to do this how you've been doing it for years. Just make sure you include this sheet as well that explains how you're doing it.
Thank you.
So I think this is gonna be our closing question because we have about 2 minutes left and you only get 30 minutes for lunch. So all of you have spoken at some point about the importance of housing and how housing is key to health outcomes. One of the challenges we know that South Carolina is facing, and so are many other states, is that there is an increasing shortage in affordable housing. And as we're doing this work, community health workers and other service organizations are sometimes finding it difficult or impossible to put people in housing. Have y'all allocated any funding to supporting the development of affordable housing or helping people pay for non-traditional affordable housing?
I can speak for Carolina Complete Health. So we are actually working on a proposal right now that actually provides a fund almost similar to a value-added service. You'll get this soon. To where, because some of the things that we're realizing is that, as you indicated, affordable housing is becoming less and less available, but then there are people who are in housing whose rent is going up $200, and that $200 is making it not affordable. So as a health plan, we're discussing how do we help the non-health opportunities members as well with staying in housing, because in some of our counties, I mean, there's a wait list for shelters. And so we're trying to create our own internal fund that will help members with security deposits, application fees to either get them housed or keep them housed.
Yeah, it's a big challenge in North Carolina too. I mean, our HSOs can use capacity building dollars to try to build infrastructure, but you know, that's not necessarily building new housing. And some of our services can pay for temporary housing, like post-hospitalization housing or first month's rent and security deposit, but not ongoing housing because of CMS regulations. So it's a challenge we're dealing with too. I don't know if you want to add anything.
Yeah, that is our biggest number one unmet need is housing, and the most expensive need as well. So again, that's why we're thinking through all the different tools we can put into place. So we have the data, right? But everybody knows in the room even without the data. We have that data not only with our map, but also the data we get from NC Care 360, that we can say how many referrals to housing can't be filled because there is no housing. So lots of nice data to show where is our need. And then other strategies and thinking through then what's the investment strategy in these domains that we can wrap around, not just the pilot areas, but other parts of the state. And so we also have a part of our toolbox is it's our investment map. We have best practices for food and housing, and it really helps guide people if they want to invest in housing and in food, what's the best things to invest in. And I have lots of conversations with our philanthropies, thinking through what's their investment portfolio over the next couple of years, and housing is usually the first thing that comes out of their mouth, and we have that opportunity to invest, and also thinking through some of the state, some of the federal dollars and state dollars that are coming down. How can we invest them into housing? But housing won't be fixed by the pilots. It really has to be that. This is where that Brady funding comes in.
So I want to thank our panelists. You did a wonderful job.